So let's move to the rendezvous technique. What is the position of the rendezvous? The rendezvous technique is done mainly if the standard cannulation fails, even after pre-cutting techniques. So this means we have here a failed cannulation. Then the next thing we do is we go for a pre-cut technique. And if this fails, then it depends. If it's non-urgent, sometimes we reattempt ERCP on another day. If it's urgent, then we have to seek another solution, and then you can perform an EUS-guided rendezvous. So this is the rendezvous procedure. So the classical way of performing a rendezvous was through PTC. So the interventional radiologist punctured the intrahepatic bile ducts, and then a wire was introduced through the papilla, and this was picked up by the duodenoscope. And now we tend to perform this with EUS, meaning that either from the stomach we puncture the left liver lobe, or from the duodenum we puncture the common bile duct, and we advance the wire through the papilla to pick it up with the duodenoscope. These are the procedural steps. So we use a therapeutic EUS scope, often in the long position, for the puncture of the common bile ducts. And we use a 19-gauge needle from within the duodenum or from within the stomach to target the left intrahepatic bile ducts. Once we are in the bile duct, we confirm position by aspirating bile. We perform a cholangiography, and then we flush the needle with aqua. To allow smooth passage of a guide wire. And we introduce a guide wire. So I think that the most ideal wire, or what I tend to use, is the 0.025 hydrophilic wire, like the VisiGlide, for example, with angulated tip. We advance the wire through the papilla. And once we are in the duodenum, we create several loops so that the wire is stable in the duodenum. We pick it up with a duodenoscope, and then we just introduce the sphincterotome over this wire. So what should we do, PTC or EUS-guided rendezvous? There's not a lot of literature. We performed a comparative cohort study, and it was a retrospective study because before 2018, February, we did all the rendezvous with PTC, and after that, we did all the rendezvous with EUS. So we had an unselected patient population, and we looked at technical success rate and complication rates. The technical success rate was higher for PTC rendezvous, 90%, and we had about 75% in the EUS rendezvous group. But I have to say that this included also the learning curve. So at the moment, we are very close to 90% technical success rate. And if you look at complication rate, this was in general comparable between both techniques, but the number of major complications was higher in the PTC group. Okay, so let's move to direct EUS-guided biliopancreatic drainage. So the choledochoduodenostomy is an EUS-guided anastomosis between the duodenal lumen and the common bile duct. We do this with lumen-opposing metal stents, and the approved indication is either a failed ERCP or a distal malignant biliary stricture. In our center, we use the hot axios stent. So there are several sizes of the hot axios stent. And for this indication, we always use the small diameter stent. And this is the stent that has a lumen diameter of 6 millimeters and a saddle length of 8.
And Stefano, do you think there's a place for sampling because it's a stenosis, or because he has chronic pen, you just leave it like this?
This is a good question, but he has EUS, so I think there is no clear mask, right? But because we entered with easy, I think we can do brushing and also biopsy, intraductal biopsy with forceps. We can use both standard forceps or a pediatric one. I will have to cut a little bit more. Bend the cannulotome, please.
The impression is a lot of fibrosis. That
Yeah.
Yeah. Absolutely. Okay, I think now we have a nice sphincterotomy. Maybe there's space for another cut, but I think it's enough. So I remove the cannulatum now. And we can proceed with the brushing.
And Stefano, if you place a metal stent, at what time would you exchange it, or just leave it 1 year, or would you exchange it after 6 months?
We usually leave the metal stent for 1 year, but pay attention to not forget, because we have cases of very difficult removal of the stent after 1 year. So we now suggest to the patient to come back in 9-10 months to be sure to be able to remove the stent. Differently for plastic multi-stent, we add one 10 French stent every 3 months until the highest number of stent is reached. Usually 4 or 5 10 French plastic stent. I don't know how you perform treatment of biliary stenosis in chronic pancreatitis. We can discuss about it, but I think it's much more comfortable for the patient to receive first a metal stent, and after that, if the treatment doesn't work, split and change to multi-plastic stent.
And do you have a lot of stent migration with the fully covered metal
No,
stents?
not so much. Not so much. No. Okay, try to pass the stenosis. Okay, now I go back, and you can start moving out and in the catheter. Yeah, perfect. Okay, you can move several times. You know, there is a study that say that if you do 30 movements of the brush in and out, you improve your accuracy. It's boring, sorry, but we can do.
Which brush do you use?
It's a standard brush. We would like to start using the brush with more traumatic brushes. You know, the one I'm talking about, but we have not succeeded in buy this new brush device. Okay, another important thing is to perform biopsy, intraductal biopsy. Usually,
Or next to the wire?
no, next to the wire. I think it's good. You can increase your accuracy.
There's some conflicting data about the brushes, like the infinity brushes. And recent data show not that much improvement with the
No guide
brush.
wire. No, not necessary. The distal stenosis I can do without guide wire. There is here the possibility to choose about guide wired forceps and standard forceps, but for distal stenosis, I think we can use a standard one.
So Stefano, say this patient was coming with a biliary plastic stent in place instead of a native bile duct,
Yeah.
and he was coming because of cholangitis after diagnosis and never had a brushing
Yeah.
in the baseline ERCP. Would you, if there was a plastic stent, would you still take brushings as the follow-up procedure for stent exchange?
No. In this case, no, because the accuracy is really low if you have already a plastic stent inside. So I would prefer to perform only biliary biopsy. So I think we should put a metal stent if you have nothing wrong and nothing against that choice.
So what kind of forceps are you using for
A standard
intraductal
one. Yeah,
upper
open.
GI biopsy?
Yeah, standard upper GI biopsy. Yeah. close.
And what is the technique? Could you describe what you're doing? When do you use fluoroscopy? How much do you press?
Yeah, this is a good point. The first thing is to have a guide wire into the bile duct. You have to follow the direction of the guide wire to be sure to be in the bile duct and not in the pancreatic duct. That can happen. In this case, we have also a plastic stent in the pancreatic duct, so it's more safe. Usually I push just a little bit of the forceps out, make up and go close to the papilla, then make fluoroscopy, be sure that the axis is correct, and move a little bit the scope, trying to go in the right direction. Okay, now open. Okay, close.
And how many passes would you make? I mean, no 30, I guess.
No, 4. Usually we do 4. There is a study from Massimiliano Modignani that demonstrated that 4 could be a good number of biopsies. But it's the only one, and it's very old. That's why we were thinking about performing another study like that to understand how many passes we have to do. I don't know in your practice if you have different advice.
Yeah, no, the number of passes, we don't often go for intraductal biopsy.
Okay.
We have EUS-FNA,
Yeah.
and then maybe make decisions based on clinical. Like in this case, I mean, the chances of malignancy are
Yeah, it's really low.
negligible, I would say, but still.
42-year-old completing US exam,
Okay, open.
chronic pancreatitis, also the contour of
Okay,
the
close.
picture is also
Okay,
helpful.
it's enough. We can put the stent. 4 centimeters. So, Peter, if you agree, I will put fully covered metal stent of 4 centimeters.
Okay. So just for the audience,
Yeah.
how do you estimate the optimal length of your stent? Can you explain us?
Yeah. In this case, it's really simple because the stenosis is really short. Usually, the first thing I do is look at fluoroscopy. If the stenosis is under the instrument, I think that 4 centimeters is enough. If you have doubt, you can pull out the cannulotome when the tip of the cannulotome is in the upper part of the stenosis, and measure how many centimeters of the cannulotome you have pulled out when the tip is in the distal part of the stenosis. This could be a trick to measure the length. If you put a plastic stent, there are some introducer, for example, those from Cook, that has 2 markers, and the distance between the 2 markers is 7 centimeters. So you can use that to measure the length of the structure.
So, and if the origin of the cystic duct was much lower and you would have to bridge it with your SEMS, would you still do it, or would you go for plastic stenting?
Probably, if there are a lot of contrast in the gallbladder, like in this case, I would prefer multiplastic stent. But in this case, I think we will not impair the cystic duct. So I'm up now.
So Stefano, you didn't need a EUS rendezvous, but if you would have needed it and you would have punctured and your guide wire is in the duodenum, do you always pick up your wire as said in the presentation, or do you cannulate next to it?
No, I think it's easier and most faster to try to go alongside the guide wire, and if you fail, you can grab the guide wire. You can start opening.
Yeah, for sure, because if you already tried, you have already a guide wire ready that you use to do first, right?
Yeah, I think you can pass alongside with another guide wire. It's often easy. Wait a moment for the peristalsis. Okay, let's go. Yeah, go. Yeah. Okay. I think it's in a good position. We have a nice biliary aerogram here, so the air passes very well into the bile duct, and sometimes you have some trouble to retrieve the introducer of the stent. You must do it carefully.
It's quite tight,
Yeah,
Mr.
yeah, it's quite tight. But now I think the procedure is finished.
Okay. Thank you very much for this interesting session, and I would like to have the correct answer to the quiz question to end the session.
It's too easy.
So which of the following statements is true? And indeed, 100% had the right answer. In general, the 19-gauge needle is used to puncture the pancreatic or biliary duct. I think the 19-gauge is indeed the first choice. Thank you very much, and I'll see you back for the last session on lumen opposing metal stents.